This discussion is going to be on the cardiovascular system, Chapter 9. Our objectives for today are to recognize the role of the physical therapist assistant in primary, secondary, and tertiary prevention of cardiovascular pathology, recognize gender differences in cardiac physiology and pathology, recognize common cardiovascular pathologies and physical signs and symptoms of worsening cardiovascular status, and recognize sternal precautions that may affect types of therapeutic activity included or excluded from postoperative cardiac plan of care. Our questions for today are, during a cardiac rehabilitation session, a patient reports chest pain and shortness of breath. The PTA measures the patient's blood pressure and finds it to be 90/60 millimeters of mercury. What is the most appropriate immediate action? A, encourage the patient to continue at a lower intensity. B, have the patient rest and monitor symptoms closely. C, administer supplemental oxygen and continue exercise. Or D, call emergency services and initiate emergency procedures. The second question is, a patient in an outpatient clinic is participating in a structured walking program post myocardial infarction. The PTA monitors the patient's vitals and notes an oxygen saturation of 92% with a heart rate of 110 beats per minute. The patient reports mild fatigue, but no chest pain. What is the best course of action? A, continue the exercise session while monitoring symptoms. B, stop the session and have the patient rest for 30 minutes. C, administer oxygen and call the physician. Or D, increase the intensity to build endurance. The cardiovascular system functions in coordination with the pulmonary system to circulate oxygenated blood through the arterial system to all cells. The deoxygenated blood is then collected from the venous system and delivered to the lungs for reoxygenation. Pathological conditions of cardiovascular system are varied, multiple, and complex. Here you can see a diagram of the blood flow through the heart. From the body, the blood flows into the heart via the superior and inferior vena cava into the right atrium. On the right side of the heart, you have the tricuspid valve, where the blood flows into the right ventricle, and the pulmonic valve, where the blood flows through the pulmonary artery, and into the lungs. CO2 is exchanged for oxygen in the pulmonary capillaries. Oxygenated blood returns to the heart via the pulmonary veins into the left atrium. On the left side of the heart, you have the mitral valve, the blood flows through the valve to the left ventricle, and the aortic valve through the aorta and into systemic circulation. The cycle repeats where oxygen-depleted blood returns via the vena cava. The layers of the heart wall include the epicardium, which is the outer layer that is composed of connective tissue and epithelium, the myocardium, which is the middle layer, which is cardiac muscle tissue and is responsible for muscle contraction, and endocardium, which is the inner layer of endothelial cells lining the chambers and valves. Here we're going to discuss the differences of arteries and veins, including their structure and function. First, we have elastic arteries, also known as conducting arteries. These are the largest, and examples include the aorta and other major branches. They have the ability to stretch and recoil with blood pressure changes, accommodating blood surges during ventricular contraction. Next, we have muscular arteries, also known as distributing arteries. They carry blood to specific organs and body areas. They are smaller in diameter, however have thicker muscular layer. They help to regulate blood flow through smooth muscle contraction or dilation. The arterioles, also known as resistance vessels, are the smallest arteries that lead to capillary networks. Smooth muscle contraction adjusts blood flow resistance, influencing blood pressure and organ blood supply. Within our veins, we have venules, which are the smallest which receive the blood from the capillaries. This is the transition of blood into the larger venous channels through the veins. Veins carry blood back to the heart. They have a high elasticity due to accommodating blood volume changes with minimal pressure shifts. They contain one-way valves to prevent backflow and ensure upward movement. Here you can see a depiction of the muscle pump mechanism. So in veins, one-way valves aid circulation by preventing backflow of venous blood when pressure in the local area is low. A local high blood pressure pushes the flaps of the valves to the side of the vessel, allowing easy flow. When pressure below the valve drops, blood begins to flow backwards but fills the pockets formed by the valve flaps, pushing the flaps together and thus blocking further backflow. Cardiac output is the volume of blood pumped by the heart in 1 minute. The equation is cardiac output is equal to stroke volume times heart rate. Stroke volume is the blood ejected by the ventricle per beat. It is influencing factors include preload, which is blood volume in the ventricle at the end of diastole, contractility, which is the strength of ventricular contraction, and afterload, which is the pressure the heart must overcome to eject blood. Our heart rate is the beats per minute and is influenced by the autonomic nervous system activity, hormonal regulation, and metabolic demands. Peripheral resistance is the resistance blood encounters as it flows through smaller blood vessels like arterioles and capillaries, primarily due to friction between blood and vessel walls. Factors influencing peripheral resistance include blood viscosity, so thicker blood increases resistance. Also vessel diameter. The smaller the diameter, the higher the resistance. The lower the diameter, the lower the resistance. So what is the role in blood pressure regulation? Vasoconstriction is the narrowing of vessels. This increases resistance and raises blood pressure. Vasodilation is the widening of vessels, decreases resistance and lowers blood pressure. Vasomotor mechanism is where arterioles' smooth muscle layer allows for constriction, which reduces diameter, increases resistance, and decreases tissue blood flow. And dilation, which increases diameter, decreases resistance, and increases tissue blood flow. An analogy is peripheral resistance is like pinching a garden hose. You pinch the hose and the pressure and flow increase. You release the pinch and the pressure and flow decrease. Systolic pressure is the pressure during ventricular contraction, and diastolic pressure is the pressure during ventricular relaxation. Peripheral resistance is the resistance to blood flow from arterial walls. It regulates arterial pressure by controlling arterial runoff, which is blood flow from arteries to arterioles. The higher the resistance, the less runoff, which equals more blood in arteries, which leads to higher pressure. Lower resistance leads to more runoff, less blood flow to arteries, and lower pressure. There are local and systemic effects. Local effects, blood flow in specific tissues and organs, and systemic effects, overall blood pressure. Overall resistance in systemic circulation is total peripheral resistance. Increased total peripheral resistance, higher arterial pressure, decreased total peripheral resistance equals lower arterial pressure. Again, systolic pressure is the pressure in the arteries when the heart is contracting, and diastolic is the pressure in the arteries when the heart is relaxed or filling. Blood pressure regulation involves a number of key factors, including cardiac output. Again, this is the blood volume pumped by the heart per minute. It is influenced by stroke volume, which is the blood ejected per beat, and heart rate, which is the beats per minute. Also, peripheral vascular resistance, resistance in blood flow in vessels, and depends on the vessel diameter, so the smaller diameter, the higher the resistance. And blood viscosity, thicker blood equals higher resistance. So blood pressure control. Blood pressure is equal to cardiac output times peripheral vascular resistance. The higher the cardiac output or peripheral vascular resistance, the higher the blood pressure. The lower the cardiac output or peripheral vascular resistance, the lower the blood pressure. Nephrosclerosis is the hardening of kidney tissue. Other common terms used are hypertensive nephrosclerosis, benign nephrosclerosis, and nephroangiosclerosis. Causes are due to chronic hypertension, which leads to damage and scarring of the kidney arteries and arterioles. The consequences include impaired kidney function and the risk of chronic kidney disease and renal failure. Blood pressure pathologies include blood flow issues or peripheral resistance issues. Hypertension is also known as high blood pressure, is characterized by elevated blood pressure levels, over 60 million cases in the US, and is defined as blood pressure more than 140 over 90 millimeters of mercury. There are a few different types of hypertension: primary or essential hypertension, which accounts for 90% of cases, and there is no identifiable cause. It is idiopathic. Secondary hypertension is caused by underlying medical conditions or external factors. Causes of secondary hypertension include medications such as corticosteroids, NSAIDs, or decongestants, alcohol consumption, kidney disease or renal failure, which disrupts blood pressure regulation, pregnancy, which can lead to gestational hypertension or preeclampsia, endocrine diseases such as hormonal disorders, acute stress, collagen disease in conditions such as systemic lupus erythematosus or scleroderma, or increased intracranial pressure. Primary hypertension risk factors include modifiable factors such as sodium intake, obesity, diabetes mellitus, hypercholesterolemia, smoking, alcohol consumption, stress, sedentary lifestyle, or hormonal imbalances. Non-modifiable factors include family history, an age of over 55, gender, and ethnicity. Secondary hypertension contributing factors include alcohol consumption, pregnancy, increased intracranial pressure, collagen disease, endocrine disorders, renal disease, medications, acute stress, and neurological disorders. Predictors of hypertension include cigarette smoking, elevated fibrinogen levels, increased lipoprotein levels, erectile dysfunction, metabolic syndrome, including dyslipidemia, increased blood pressure, elevated glucose levels, to name a few. Early stage hypertension often presents without noticeable symptoms, referred to as the silent killer. Regular monitoring is crucial, especially for those at risk. Late stage hypertension symptoms and complications include headaches, which can include persistent or severe headaches due to increased pressure in brain blood vessels, vertigo, which is dizziness or spinning sensation from compromised blood flow to the brain, a flushed face, which is redness or facial flushing due to increased blood flow or blood vessel dilation. Spontaneous nosebleeds due to fragile blood vessels in the nose, which may rupture. Blurred vision from changes in the blood flow to the eyes or retinal blood flow vessel damage. Nocturnal urinary frequency due to increased need to urinate at night, indicating kidney dysfunction or fluid retention. Morning headaches, which often suggest elevated blood pressure during sleep. Excessive morning blood pressure, where elevated blood pressure readings in the morning, especially in older adults, increasing the risk of stroke and cardiovascular events. Regular blood pressure monitoring is crucial so that effective management can help prevent complications and improve long-term outcomes. Hypertension management includes lifestyle changes such as aerobic exercise, smoking cessation, reduced sodium diet, low-fat diet, weight loss, and stress reduction. Drug therapy includes diuretics, which increase water and sodium excretion by the kidneys, ACE inhibitors, which decrease angiotensin II synthesis, alpha blockers, which decrease sympathetic tone of blood vessels, which lead to vasodilation and decreased peripheral resistance, beta blockers, which decrease heart rate and contractility, which lead to decreased cardiac output, which leads to decreased blood pressure, and calcium channel blockers, which are vasodilators and decrease peripheral resistance. PTA implications include checking vital signs prior, during, and post-exercise. You're checking for sudden changes in blood pressure with any exercise. Monitoring people taking NSAIDs and antihypertensive medications. Gradual aerobic exercise program. Heavy isometrics and weightlifting could potentially be harmful. And training intensity does not need to be high, so low intensity 3 times a week is recommended. Cardiovascular disease signs and symptoms include chest pain, shoulder, neck, jaw, and arm pain, palpitations, syncope, fatigue, diaphoresis, dyspnea, nausea, vomiting, cyanosis, and claudication. Cardiovascular disease, particularly coronary atherosclerosis, is the leading cause of hospitalization and death in older adults in the U.S. Disease-independent changes in the aging heart include reduction in myocytes and conduction tissue cells, development of cardiac fibrosis, a reduction in calcium transport across membranes, lower capillary density, impaired autonomic reflex control. Age-related cardiac changes without functional impact include epicardial fat deposition, where fat accumulates around the heart, often considered part of aging, but typically without functional consequences. And brown atrophy due to lipofuscin deposits. Intracellular lipofuscin deposits in the heart cells are indicative of aging, but generally not impairing heart function. Even healthy, active, older adults experience reduced blood flow to the skin during exercise. The heart of older individuals has to work harder under the same conditions compared to younger individuals. A review of heart valves. Heart valves allow blood to flow from one chamber to another. They allow blood to flow out of the heart in one direction and controls the flow of blood through the heart by opening and closing during the contraction of the heart. Heart problems secondary to valve impairments can be caused by infections or congenital deformities, also acquired diseases. Types of valve deformities include functional, impacting the function of the valve without structural changes, and anatomic, where structural changes affecting the valve's shape and function. Common manifestations include stenosis, which is narrowing or constriction of the heart valve, limiting its ability to open fully, often caused by scarring and abnormal deposits on the valve leaflets. The effects include obstructed blood flow and increased workload on the chamber behind the affected valve. The aortic and pulmonary valves are often affected, and treatment includes surgical replacement, which may be necessary to relieve symptoms and restore blood flow. Also, insufficiency or regurgitation, which is failure of the heart valve to close properly, allowing the blood to flow back into the heart chamber during contraction. The effects involve backward blood flow, which increases the workload, leading to chamber dilation. A prolapse is the enlargement of the valve leaflets, particularly in the mitral or tricuspid valve, bulging backward into the atrium. Valve conditions may initially be asymptomatic, but can lead to cardiac muscle dysfunction over time. In severe cases, surgical intervention, including valve replacement, may be necessary. Mitral stenosis is often caused by rheumatic heart disease and is more common in women. Clinical features in mild cases often are asymptomatic, with normal left atrial pressure and cardiac output. Moderate cases include dyspnea and fatigue due to rising left atrial pressure and reduced cardiac output. And in severe cases, high left atrial pressure causes pulmonary venous congestion, dyspnea, fatigue, and right ventricular failure. Symptoms include orthopnea and paroxysmal nocturnal dyspnea, which may occur due to increased pulmonary blood volume when lying down. Mitral regurgitation has various causes, including ischemic heart disease being a common one, and is associated with female gender, lower BMI, and older age. Clinical features in acute cases include abrupt rise in left atrial pressure, potentially leading to pulmonary edema, and in chronic cases, progressive left atrial enlargement with exertional dyspnea, fatigue, and possible development of atrial fibrillation, and may eventually lead to left ventricular failure. Mitral valve prolapse affects 2 to 6% of adults and is more common in young women. There are slight structural variations in the mitral valve, and the leaflets will billow back into the left atrium during ventricular contraction. It may be asymptomatic or present with exertional dyspnea, exercise-induced fatigue, and complications such as atrial fibrillation. Marfan syndrome is a genetic disorder affecting connective tissue strength. Clinical features include weakness in connective tissue that affects structures like the mitral valve. Mitral valve regurgitation can cause increased pressure in the pulmonary bed, leading to pulmonary hypertension. Symptoms may include paroxysmal nocturnal dyspnea. Coronary artery disease is synonymous with ischemic heart disease and coronary heart disease. It involves the narrowing or blockage of coronary arteries, which reduce oxygen supply to the myocardium, causing ischemia and potentially infarction. Clinical manifestations include angina or chest pain or discomfort, shortness of breath, fatigue, and in severe cases can lead to myocardial infarction or sudden death. There are various types of arterial sclerosis. Atherosclerosis is the most common form, involving fatty plaques in the inner layer of the arteries, including coronary arteries. Monkbird's arteriosclerosis affects the middle layer of the arteries, causing destruction of muscle and elastic fibers and the formation of calcium deposits. And arteriolar sclerosis is thickening of the small arteries. All three types can be present in the same individual, affecting different blood vessels. Atherosclerosis is a major contributor to coronary artery disease and other cardiovascular diseases. Management involves lifestyle modifications, including diet and exercise, medications, interventions such as angioplasty or bypass graft, which aim to prevent or alleviate arterial narrowing and reduce cardiovascular risk. Cardiovascular disease has a number of different risk factors, including demographics, where it is a higher risk in African and American Mexican women, as well as Black men. Other risk factors include age, family history, smoking, high blood pressure, high cholesterol, diabetes, obesity, unhealthy diet, physical inactivity, excessive alcohol consumption, and stress. The types of vascular disease are coronary artery disease, which affects arteries supplying the heart and leads to conditions like angina and heart attack. Cerebrovascular disease, which affects arteries supplying the brain and leads to conditions like stroke or transient ischemic attacks, or TIAs. Peripheral vascular disease, which affects arteries outside the heart and brain, typically in the legs, causes reduced blood flow, claudication, and potential complications like ulcers and gangrene. An aneurysm is an abnormal bulging or ballooning of the blood vessels and can occur in various body locations and may rupture if untreated. And intestinal infarctions, where reduced blood supply to the intestines, which is often due to atherosclerosis or blood clots. This leads to tissue damage and potentially life-threatening complications. This is an updated model of atherosclerosis. Our atherosclerosis begins with an injury to the endothelial lining of the artery, allowing circulating lipoproteins to penetrate into the intimal layer. Penetration of the lipoproteins into the smooth muscle cells of the intimal layer leads to formation of fatty streaks, initiating the development of a coronary lesion. The coronary lesion initially grows outward in a compensatory manner known as positive remodeling to maintain an open lumen. This involves the formation of a fibrous cap to separate the plaques from the arterial lumen. Gradually, the plaque build up, pressing inward into the lumen, obstructing blood flow, and potentially leading to rupture or thrombus formation. A blood clot, known as intraplaque thrombosis, may form within the plaque, contributing to its stability or instability. Plaques with thin fibrous cap and packed with viscous cholesterol and white blood cells are more likely to rupture. Rupture of the plaque and subsequent thrombus formation can lead to myocardial infarction or stroke. Vascular disease, including atherosclerosis, is considered a disease of the arterial wall. This concept emphasizes that the pathology occurs within the vessel wall itself rather than just within the lumen. Symptoms of coronary artery disease include angina pectoris, which is chest pain or discomfort due to reduced blood flow to the heart muscle; myocardial infarction, which is a heart attack caused by prolonged blood flow blockage leading to tissue damage or death. Death can occur in severe cases of coronary artery disease. Non-modifiable risk factors for coronary artery disease include age. The incidence of coronary artery disease increases with age. Men generally have a higher prevalence, but women may experience heart attacks later due to hormonal factors. A family history of coronary artery disease or premature heart disease increases risk. African American, Hispanic, and South Asian populations are at higher risk. Chronic bacterial or viral infections may contribute to coronary artery disease development. Modifiable risk factors include hypertension, dyslipidemia, diabetes mellitus, smoking, obesity, physical inactivity, unhealthy diet, stress, and excessive alcohol consumption. These can be addressed with lifestyle changes and medical interventions to reduce the risk of coronary artery disease and related complications. Radioisotope studies are used to determine myocardial perfusion, or the blood flow to the heart muscle, and involves injecting a radioactive tracer for blood flow visualization. It identifies areas of reduced blood flow, indicating potential ischemia or infarction. The test described here is a stress test, also known as an exercise stress test or cardiac stress test. It is used in medicine and cardiology to assess the heart's response to external stress, typically induced by exercise in a controlled clinical environment. Cardiovascular disease treatment includes pharmacology to decrease the oxygen demand and increase blood flow to the heart. These medications include nitrates, beta blockers, calcium channel blockers, antiarrhythmics, antihypertensive, digitalis, diuretics, aspirin, hypolipidemic, and thromboembolic therapy. Surgical interventions include percutaneous transluminal coronary angioplasty, coronary stents, coronary artery bypass graft, transplantation, ventricular assistive device, and diet low in sodium, cholesterol, and weight reduction. Percutaneous transluminal coronary angioplasty can open an occluded coronary artery without opening the chest, which is an important advantage over bypass surgery. Once coronary angiography has been performed to determine the presence and location of an arterial occlusion, a guide catheter is threaded through the femoral artery into the left coronary artery. When the angiography shows the guide catheter positioned at the site of the occlusion, the uninflated balloon is centered in the obstruction. A smaller double lumen balloon catheter is inserted through the guide catheter. A balloon is inflated, compressing the plaque against the arterial wall, and deflated until the angiogram confirms a reduced pressure gradient in the vessel. The balloon is removed and the artery is left unoccluded. Here you can see the steps of application of a coronary stent. In picture A, you see a severely occluded coronary artery. B and C is blocked coronary artery, can be held open using a balloon expandable device called a coronary stent. And in picture D, the stent maintains an open vessel, allowing blood to pass through freely. Biodegradable stents are under development and reduce or eliminate problems associated with metal stents. Delivery of drugs or gene therapy to inhibit intimal hyperplasia and prevent post-angioplasty restenosis is under investigation as well. Coronary artery bypass graft involves grafting a healthy blood vessel, such as the saphenous vein from the leg or internal mammary artery from the chest, to bypass a blocked or narrow coronary artery. The graft provides a new pathway for blood flow, allowing oxygen-rich blood to reach the heart muscle. It is recommended for individuals with severe coronary artery disease who have multiple blockages or have experienced heart muscle damage. It is also considered when medications or angioplasty have not been effective. A traditional CABG is a sternotomy, or an opening in the chest through the breastbone, provides access to the heart. There's an off-grid CABG, which is performed without a heart-lung bypass machine. And minimally invasive CABG involves smaller incisions and specialized instruments to avoid full sternotomy. A CABG helps to relieve symptoms of coronary artery disease such as angina, improves blood flow to the heart muscle and reduces the risk of heart attack, and enhances overall quality of life for patients with coronary artery disease. The recovery involves a hospital stay, typically lasts several days to a week. Follow-up recovery period includes rehabilitation and may last a few weeks to months. Most patients return to normal activities after recovery, though this varies individually. CABG is a critical treatment for severe coronary artery disease, providing improved blood flow and alleviating symptoms and other treatments when other treatments are inadequate. CABG exercise management includes knowing the indications to terminate or modify exercise, understanding sternal precautions after surgery, progressive activity to increase activity tolerance, a focus on use of lower extremity derived aerobic exercises and upper extremity range of motion, and monitoring vitals closely using the rate of perceived exertion scale. Here is an example of the rate of perceived exertion, and the target for cardiac rehab would be between 11 and 14. Indications for discontinuing or modifying exercise include a new onset or easily provoked anginal chest pain, increasing frequency, intensity, or duration of angina, discomfort in the upper body, including chest, arm, neck, or jaw, or chest pain unrelated to chest incision, fainting or lightheadedness or dizziness, sudden or severe dyspnea, severe fatigue or muscle pain, nausea or vomiting, back pain during exercise, bone or joint pain or discomfort during or after exercise, and severe leg claudication. Clinical signs include pallor, peripheral cyanosis, cold or moist skin, staggering gait or ataxia, confusion or blank stare in response to inquiries, a resting heart rate of more than 130 beats per minute or less than 40 beats per minute, more than 6 arrhythmias per hour, frequent premature ventricular contractions, uncontrolled diabetes mellitus with blood glucose more than 250, oxygen saturation less than 90, acute infection or temperature more than 100 degrees Fahrenheit, persistent drainage or change in drainage from the incision, increased swelling, tenderness, or redness around any incision site, inability to converse during activity, blood pressure abnormalities, a fall in systolic blood pressure with an increase in workload, specifically a decrease of 10 millimeters of mercury or more below any previously recorded blood pressure, accompanied by other signs or symptoms, a rise in systolic blood pressure above 250 millimeters of mercury or a diastolic blood pressure above 115, signs of central nervous system involvement, including confusion, delirium, cognitive decline, encephalopathy, seizure, or stroke. Sternal precautions include a rise in systolic blood pressure above 250 or diastolic above 115, Significant ECG changes. No pulling up in bed during acute care is allowed. Handheld assist during mobilization may be required instead of assistive device, at least initially. No pushing, pulling, or lifting more than 5 or 10 pounds. No driving for 4 weeks post-op. Some may require 6 to 8 weeks. Full neck, shoulder, and torso range of motion may be permitted as long as the sternum is stable, but not if sternectomy with skin or muscle flap is present, or the presence of a flap limits the range of motion to 90 degrees, flexion or abduction, or to the point of movement at the chest wall or rib cage. Also, avoid horizontal abduction with extreme external rotation, sternal splinting for pain, especially during coughing. Progression is based on patient tolerance and signs and symptoms of wound healing. Once the incision is fully healed, scar mobilization is permissible. The usual precautions for scar mobilization apply, including mobilizing the tissue in the direction of the scar before using a cross-traverse technique and mobilizing toward the scar rather than away from the scar to avoid overstretching the healing tissue. Angina pectoris is primarily caused by coronary artery disease, where the coronary arteries are narrowed or blocked due to atherosclerotic plaque. This reduces the heart's blood supply, especially during times of increased demand, leading to ischemia. Symptoms include chest pain or discomfort, typically described as pressure, squeezing, or heaviness or tightness. Pain may radiate to areas like the left shoulder, arm, neck, jaw, or back. In some cases, angina may not present with chest pain, but may include fatigue, shortness of breath, weakness, nausea, indigestion, or sweating. The types of angina include stable angina, which is predictable and occurs during physical exertion or stress, and relieved by rest or nitroglycerin. Unstable angina occurs at rest or with minimal exertion, and more severe and may indicate an impending heart attack. Variant angina is caused by temporary spasms of the coronary artery leading to reduced blood flow and can occur at rest and often at night. Microvascular angina results from dysfunction of the small coronary vessels and can occur without obvious blockages in the larger coronary arteries. Treatment goals include relieving symptoms and improving quality of life and reducing the risk of heart attack. Medications include nitroglycerin, which relieves chest pain and improves blood flow, beta blockers to reduce heart rate and oxygen demand, calcium channel blockers relax coronary arteries and improve blood flow, and aspirin helps reduce clot formation and prevent heart attacks. Interventions may include angioplasty and CABG, which may be considered for more severe cases. Management includes rest and avoid activities that trigger symptoms. Nitroglycerin should be used at the time of onset to relieve symptoms. And prophylactic use of nitroglycerin before activities likely to induce angina can help prevent episodes. PTA implications include rest in a seated or upright position, administering sublingual nitroglycerin, monitor pulse and respiration, monitor for signs of orthostatic hypotension, administer oxygen as ordered, call EMS if symptoms persist for more than a few minutes. Myocardial infarctions are more likely to occur in the early morning hours and during the winter holiday season. The majority of MIs result from coronary thrombus at the site of atherosclerotic stenosis. Risk factors include smoking, hypertension, hyperlipidemia, diabetes, obesity, sedentary lifestyle, and family history of heart disease. The pathophysiology involves occlusion of the coronary artery by a clot depriving the muscle the heart muscle or myocardium of oxygen, leading to ischemia and necrosis. This typically occurs due to the rupture of atherosclerotic plaque, leading to clot formation and blockage of the artery. Symptoms include chest pain or discomfort described as pressure, squeezing, or tightness, shortness of breath and nausea, sweating, vomiting, and back pain radiating to arms, back, neck, jaw, and stomach. Treatment involves immediate medical attention and is crucial to minimize damage. Restoring blood flow using thrombolytics, percutaneous coronary intervention, and coronary artery bypass graft in severe cases. Beta blockers slow the heart rate and reduce oxygen needs. Preventing complications can include the use of statins to reduce cholesterol and antiplatelet agents such as aspirin to prevent further clot formation. Complications include arrhythmias, heart failure due to damage to the heart muscle, and cardiogenic shock, as well as death if not treated promptly. Electrocardiographic alterations associated with the 3 zones of myocardial infarction as seen in this image. Clinical manifestations include sudden sensation of pressure, crushing chest pain with radiation to arms, throat, and neck. Nausea, vomiting, and diaphoresis are common. Women may experience different symptoms, including shortness of breath in the middle of the night, chronic unexplained fatigue, pain in the mid-thoracic spine, anxiety, and heartburn not relieved with antacids. 80% survive when transported to a coronary care unit, and prognosis depends on the size, location, and the amount of damage caused by the myocardial infarction. Emergency treatment involves ventricular defibrillation, CPR only in case of asystole, rest, and thrombolytic agents. Complications can include systemic organ failure, the kidneys are the most affected, and cerebral ischemia leading to mental injury or central nervous system dysfunction. Long-term medical treatment includes coronary artery bypass graft, anticoagulant therapy, and cardiac rehab programs that include exercise, dietary, and lifestyle modifications. Contraindications to exercise post-MI are listed here on the slide. Cardiac rehabilitation is important for any patient treated for cardiac disease. It includes education and exercise and begins early after surgical intervention. It includes individualized prescriptive exercises using metabolic equivalents or METs as guidelines for exercise prescription, monitoring vital signs using the rate of perceived exertion, limits on heart rate after surgery, monitoring during exercise, and monitoring SpO2, heart rate, respiratory rate, blood pressure, and signs and symptoms during, during, and post-exercise. Indications for stopping or modifying exercise include symptoms such as a new onset or provoked anginal chest pain, increasing frequency, intensity, or duration of angina, discomfort in the upper body, including chest, arm, neck, jaw, chest pain unrelated to chest incision, fainting, lightheadedness, or dizziness, sudden severe dyspnea, severe fatigue or muscle pain, nausea or vomiting, back pain during exercise, bone or joint pain or discomfort during or after exercise, and severe leg claudication. Signs for stopping or modifying exercise include pallor, peripheral cyanosis, cold, moist skin, staggering gait or ataxia, confusion or blank stare in response to inquiries, resting heart rate more than 130 beats per minute or less than 40 beats per minute, more than 6 arrhythmias per hour, frequent premature ventricular contractions, uncontrolled diabetes, SpO2 less than 90, acute infection or temperature more than 100.4, persistent drainage or change in drainage from any incision, increased swelling, tenderness, or redness around the any incision, inability to converse during activity, decreased systolic blood pressure with increased workload, increased systolic blood pressure more than 250 or diastolic more than 115, central nervous system involvement. Congestive heart failure is a condition where the heart is unable to pump enough blood to meet the body's needs, leading to circulatory congestion and impaired organ function. The pathophysiology includes structural changes in the heart, often resulting from a cardiac event like a myocardial infarction, or MI. It includes loss of myofilaments, which are the protein filaments in muscle cells, apoptosis, which is cell death, disturbances in calcium homeostasis, alterations in receptor density, and signal transduction and collagen synthesis alterations. These structural changes impair the heart's ability to pump blood effectively, leading to circulatory congestion and failure. Clinical manifestations include pulmonary congestion, which is backup of blood into the pulmonary veins, which leads to increased pressure in the pulmonary capillaries, causing pulmonary congestion and hypertension. CHF may affect both sides of the heart or primarily one side, the left or the right. The types of heart failure include systolic heart failure, which is impaired contraction of the heart muscle, which leads to decreased ejection fraction, which is the amount of blood the heart pumps out with each contraction. Or diastolic heart failure, where there's impaired relaxation of the heart muscle, leading to abnormal filling during diastole. There's also left-sided heart failure, which primarily affects the left side of the heart, causing pulmonary congestion and symptoms like dyspnea. And right-sided heart failure, which primarily affects the right side of the heart, causing systemic congestion and symptoms like peripheral edema or swelling in the legs and feet. The etiology includes pre-existing heart conditions such as coronary artery disease, hypertension, and valvular disease. Also alcoholism, myocarditis, or decreased desensibility of the heart muscle. Pathogenesis involves structural changes in the heart, often initiated by cardiac events such as myocardial infarction or long-standing hypertension, leading to impaired cardiac function and circulatory congestion. It is generally diagnosed with echocardiogram to assess the cardiac structure and function, including heart size, chamber volumes, and ejection fraction. I'm sorry, that was an echocardiogram. Electrocardiogram, or ECG, is to detect abnormal heart rhythms or electrical disturbances in the heart. Chest radiography is to visualize signs of pulmonary congestion or fluid accumulation in the lungs. Arterial blood gas analysis, or ABGs, to assess oxygenation and acid-base balances in the blood. Blood tests to evaluate cardiac markers such as BNP or troponin, and renal function, as kidney function can be affected in CHF. Clinical assessment involves evaluation of signs and symptoms like dyspnea, edema, fatigue, and exercise intolerance. Left-sided heart failure, or left ventricular failure, occurs when the left ventricle cannot pump blood efficiently to meet the body's metabolic demands. This leads to inadequate perfusion of tissues and fluid buildup in the lungs. Etiology includes hypertension, where chronic high blood pressure causes left ventricular hypertrophy or enlargement of the heart muscle and impairs the heart's ability to contract effectively, leading to failure. Ischemia, which is the reduced blood flow to the heart, commonly due to coronary artery disease, causes damage to the myocardium and impairs the left ventricular function. Clinical manifestations include dyspnea or shortness of breath caused by pulmonary congestion, especially during exertion or when lying flat. Paroxysmal nocturnal dyspnea or sudden shortness of breath during sleep, often forcing the person to sit or stand to relieve symptoms. Orthopnea, which is difficulty breathing while lying flat, which improves when sitting up or standing due to the fluid redistribution from the legs to the lungs in a supine position. Fatigue and muscle weakness due to decreased cardiac output and insufficient oxygen delivery to tissues, resulting in overall weakness and fatigue. Tachycardia, or increased heart rate, is a compensatory mechanism where the heart rate increases in an attempt to maintain cardiac output despite the reduced stroke volume. Decreased peripheral blood flow due to reduced cardiac output can lead to poor perfusion of the peripheral tissues, resulting in cold extremities and diminished pulses. Decreased renal perfusion activates the renin-angiotensin-aldosterone system, which promotes sodium and water retention. This exacerbates fluid overload and can lead to symptoms like oliguria, which is reduced urine output, and peripheral edema. Right ventricular failure, or right-sided heart failure, occurs when the right ventricle is unable to pump the blood effectively to the lungs for oxygenation, leading to fluid buildup in the systemic circulation and pulmonary congestion. Etiology involves left-sided congestive heart failure. Elevated pressures in the left side of the heart can cause pulmonary congestion. This increased pressure in the lungs is transmitted to the right side of the heart, eventually leading to right ventricular failure. Also, pulmonary disease. Chronic obstructive pulmonary disease, or COPD, pulmonary embolism, and other lung conditions can directly increase the right ventricular workload, contributing to right-sided CHF. Clinical manifestations include dependent edema, where swelling in the lower extremities due to fluid retention. This edema tends to worsen throughout the day and may improve when the patient lies down in a recumbent position. Jugular venous distension is observable bulging or distension of the jugular veins in the neck. This is a sign of increased central venous pressure, which occurs when the right side of the heart cannot effectively pump blood, causing blood to back up. Right upper quadrant and abdominal pain due to hepatic congestion or fluid buildup in the liver can cause discomfort or pain in the right upper abdomen. This is often accompanied by hepatomegaly, which is enlarged liver, a sign of systemic fluid overload. Cyanosis of nail beds, which is a blue discoloration of the nails due to reduced oxygen levels in the blood or hypoxemia, indicating poor circulation to peripheral tissues due to impaired right ventricular function and inadequate pulmonary circulation. Here you can see the difference in left ventricular failure and right ventricular failure. Medical management includes finding out the underlying problems and addressing those. Non-pharmacological interventions include diet or including sodium restriction, exercise and lifestyle changes. Pharmacological interventions include diuretics, beta blockers, and ACE inhibitors, and also surgery. Surgery is indicated to treat the underlying cause. This includes a CABG, heart transplant, and cardiac synchronization therapy, or like a pacemaker device. Implications for the PTA. Positioning plays a crucial role in managing patients with congestive heart failure to alleviate symptoms and prevent complications. High Fowler's position is elevating the head of the bed to at least 20 inches above the level, helps to reduce pulmonary congestion by facilitating diaphragmatic expansion and improving ventilation. This position can also alleviate dyspnea by reducing pressure on the diaphragm. Dependent position of the legs is keeping the legs in a dependent position helps decrease venous return to the heart, thereby reducing preload and preventing further fluid accumulation. This position assists in minimizing peripheral edema and venous congestion. Avoid elevating the feet. Elevating the patient's feet should be avoided because it can increase venous return to the heart, leading to increased preload and exacerbating heart failure symptoms. Instead, maintaining the legs in a dependent position is preferred to promote venous return. Range of motion exercises. Encouraging the patient to perform range of motion exercises helps decrease the venous pooling in the extremities and promote circulation. These exercises can prevent venous stasis and reduce the risk of thrombophlebitis. It is essential to monitor patients for signs of complications such as thrombophlebitis, indicated by unilateral swelling, calf pain, and pallor. Early detection of these signs allow for prompt intervention and prevents further complications. Trendelenburg can compromise ventilation, venous return, and increase preload, as well as increase myocardial wall stress. So it is important to not place these patients in a Trendelenburg position. Arrhythmias or dysrhythmias are a disturbance of the heart rate or rhythm caused by an abnormal rate of electrical impulse. Normal heart rhythm is controlled by the SA node, which is the heart's natural pacemaker. It generates impulses that travel through the conduction system, stimulating atria and ventricles to contract and pump. The types of arrhythmias include rate abnormalities, which can be too fast or too slow, or rhythm abnormalities, such as irregular rhythms. They can occur in the atria or ventricles. Causes of arrhythmias include intrinsic factors, such as SA abnormalities and conduction pathway deficits. Heart conditions such as coronary artery disease, heart failure, and structural defects can also cause arrhythmias. Secondary factors include electrolyte imbalances, medication side effects, and stimulants such as caffeine and nicotine. Structural changes include hypertrophy from myocardial infarction, valvular disease leading to pressure and volume overload, and conduction tissue degeneration with aging or disease. Clinical manifestations include symptoms such as palpitations, chest pain, dizziness, lightheadedness, syncope, shortness of breath, fatigue, and anxiety. Asymptomatic cases can be detected during routine evaluations. Common tests used to diagnose are EKG, Holter and event monitoring, stress testing, echocardiography, and electrophysiological studies. Treatment depends on the cause and severity. Medications such as antiarrhythmics, procedures such as electrical cardioversion or catheter ablation, devices such as pacemaker, and implantable cardioverter or defibrillators, and lifestyle changes such as diet, exercise, and stimulant avoidance. Here is an overview of the different arrhythmias and treatments. Arrhythmia classifications. Atrial fibrillation is a rapid irregular atrial contraction. Symptoms include palpitations, chest pain, dyspnea, and dizziness. Treatment involves rate control through medications, rhythm restoration through electrical or pharmacological cardioversion, and stroke prevention through anticoagulants. Ventricular fibrillation is uncontrolled ventricular contractions, which leads to cardiac arrest. Treatment involves defibrillation, immediate shock to depolarize the heart muscle and restore rhythm, and emergency care is critical for survival. A heart block is an impulse conduction delay or blockage in the heart's electrical system. Causes are SA node misfiring, conduction pathway abnormalities. Treatment involves pacemaker placement to regulate heart rate and restore conduction. Sick sinus syndrome is dysfunction of the SA node due to aging, coronary artery disease, or medications. Symptoms include fatigue, dizziness, syncope, and irregular heartbeats. Treatment involves symptom control through medications to regulate heart rate and pacemaker placement to maintain adequate rhythm in severe cases. An aneurysm is abnormal stretching or dilation in the wall of an artery, vein, or heart with a diameter at least 50% greater than normal. It is caused by vessel wall weakening due to trauma, congenital vascular disease, infection, or atherosclerosis. It leads to the formation of a permanent sac-like structure. The pathogenesis involves plaque formation that erodes the vessel wall, predisposing it to stretching and sac formation. Stretching of the media produces a weak, thin layer of necrotic muscle and fibrous tissue that bulges with each systole. Over time, the aneurysm becomes more fibrotic, but continues to bulge with each heartbeat. Thoracic aortic aneurysms can result in a tear in the intima due to elevated blood pressure, leading to rapid disruption and rupture of the aortic wall. Clinical manifestations: aneurysms may be asymptomatic. Symptoms depend on the size, position, and rate of growth. Persistent, vague pain in the substernal, back, neck, or jaw regions may occur as the aneurysm enlarges and encompasses adjacent structures. Severe sudden pain may indicate impending rupture, a life-threatening emergency. Diagnosis is done through physical examination, imaging studies, such as ultrasound for the first line for abdominal aneurysms. CT angiography is the gold standard for precise aneurysm size and location. MRI is useful for thoracic and cerebral aneurysm. Chest x-ray can show a widened mediastinum in thoracic aneurysms. An echocardiogram for aneurysms involving the heart. Management involves conservative management, such as monitoring with regular imaging for small stable aneurysms, blood pressure control with beta blockers and ACE inhibitors, lifestyle modifications such as smoking cessation and cholesterol management. Surgical interventions involve endovascular repair, which is minimally invasive stent placement, open surgical repair for large or ruptured aneurysms, and emergency surgery for ruptured aneurysms, which is time critical. Also, patient education for recognizing warning signs and the importance of medication adherence and regular follow-ups. Peripheral vascular disease encompasses pathologic conditions of blood vessels supplying the extremities and major abdominal organs, and can affect both arteries and veins, leading to compromised blood flow. Differentiation from peripheral artery disease and peripheral arterial disease, a subset of peripheral vascular disease affecting arterial blood vessels only, often due to atherosclerosis. Peripheral vascular disease includes arterial, venous, and lymphatic disorders. Lower extremities are more commonly affected than upper extremities. Upper extremity involvement is less common but can still occur, especially in conditions like thoracic outlet syndrome or Buerger's disease. The pathophysiology is atherosclerosis, which is the most common cause of peripheral vascular diseases. Thrombosis or embolism can acutely block blood flow, or chronic venous insufficiency, which results from dysfunction of venous valves. Clinical manifestations of arterial peripheral vascular disease, intermittent claudication, which is cramping pain with exertion relieved by rest, rest pain, which is severe cases and is worse at night and relieved by dangling the leg, cool, pale, or cyanotic extremities with diminished pulses, non-healing ulcers or gangrene. Venous peripheral vascular disease involves edema, especially in the lower legs and ankles, skin changes such as hyperpigmentation or stasis dermatitis, and venous ulcers typically on the medial malleolus, and leg pain that improves with elevation. Diagnosis involves history and physical examination, which is key to differentiating arterial versus venous disease. Ankle brachial index, which is a non-invasive test to assess arterial perfusion. Doppler ultrasound, which visualizes blood flow and detects blockages or valve dysfunction. CT or MR angiography provides detailed vascular imaging. And venography or for venous evaluation. Management involves lifestyle modifications such as smoking cessation, exercise, and dietary changes. Medications include antiplatelet agents, statins for lipid management, and antihypertensive to control blood pressure. Surgical interventions include angioplasty and stenting to open narrowed arteries, bypass graft for severe arterial blockage, endovenous laser therapy or sclerotherapy for venous insufficiency, and thrombectomy or embolectomy for acute arterial occlusions. Wound care is essential for ulcer management and infection prevention. Inflammatory disorders associated with peripheral vascular disease are usually immunologic in nature, involves inflammation of blood vessels, and is often accompanied by a thrombus formation, vasospasm, and can progress to end-stage organ damage if untreated. Vasculitis is inflammation of the arteries and veins causing vessel damage and luminal changes that impair blood flow. The etiology is autoimmune disorders and infections or drug reactions that trigger an immune response. The pathogenesis includes vessel wall inflammation that leads to edema and necrosis, luminal narrowing or occlusion due to thrombus formation, fibrous and scarring of the vessel wall, aneurysm formation from weakened vessel walls as well. Types of vasculitis include Buerger's disease, which is segmental vasculitis of small, medium peripheral arteries and veins. It's strongly linked to smoking and can lead to ulcers, gangrene, and digit amputation. Kawasaki disease is systemic vasculitis, primarily affecting children, and can cause coronary artery aneurysms and myocarditis. Clinical manifestations include neurological symptoms like peripheral neuropathy, paresthesias, muscle weakness and atrophy. Systemic symptoms include fever, fatigue, weight loss, skin lesions, purpurea, and ulcers. Organ-specific signs involve renal involvement and GI symptoms such as abdominal pain and bleeding. Diagnosis is done through clinical assessment of symptom patterns and physical findings, angiography, ultrasound, or MRI to assess vessel abnormalities, histopathology or vessel biopsy to confirm inflammation and immune cell infiltration, as well as laboratory tests to look for markers of systemic inflammation or autoantibody panels. Management includes pharmacological treatment with glucocorticoids, immunosuppressants, and antiplatelet or anticoagulant therapy. Lifestyle modifications such as smoking cessation and cardiovascular risk reduction. Surgical interventions such as bypass grafting or angioplasty for severe vascular occlusions, or amputation and irreversible ischemic damage. Arterial occlusive diseases are conditions characterized by the narrowing or blockage of arteries leading to reduced blood flow and potential tissue damage. It can cause pain, disability, and tissue necrosis, especially in the extremities. Primary cause is atherosclerosis. Causes and contributing factors include atherosclerosis, which is the most common cause, trauma, which is direct injury to the vessels that can cause occlusion or trigger a clot formation, a thrombus or an embolism. A thrombus is a stationary blood clot forming within the vessel, and an embolism is a clot or particle traveling through the bloodstream, lodging into smaller arteries. Also vasculitis, which is an inflammatory vessel disorder, such as Berger's disease or Kawasaki disease, or vasomotor disorders, which are abnormal vascular tone affecting blood flow, such as Raynaud's disease or Raynaud's phenomenon, which is episodic vasospasm in response to cold or stress, and complex regional pain syndrome, which is dysregulated nerve signals affecting vascular control. Arterial punctures, which are complications from invasive procedures, and chronic mechanical irritants such as structural compression of arteries, as seen with thoracic outlet syndrome or cervical ribs compressing on the subclavian artery. Pathophysiology involves endothelial injury, which triggers platelet aggregation and fibrin deposition, inflammatory cell infiltration, and progressive lumen narrowing due to plaque growth or clot formation or embolism. This leads to impaired perfusion, which is reduced oxygen and nutrient delivery to tissue, leading to tissue ischemia and necrosis. And collateral circulation the body may develop alternative pathways, but often insufficient in severe blockages. Clinical manifestations involve the 6 P's of acute arterial inclusion: pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, which is where the limb assumes environmental temperatures. Chronic symptoms include intermittent claudication, rest, pain with rest, and trophic changes such as thin skin, hair loss, brittle nails, and ulcers. Peripheral arterial disease, also known as arterial sclerosis obliterans. Symptoms occur distal to the occlusion. Surgery is indicated when pain persists at rest. An ankle brachial index is used to assess blood flow to the legs. Arterial occlusive diseases etiology include atherosclerosis, cigarette smoking, diabetes, hypertension, and dyslipidemia. Pathogenesis is plaque buildup, narrows arteries, reducing blood flow. Clinical manifestations include claudication, pain, pallor, weakness, and pulselessness. Symptoms appear when the lumen diameter is reduced by 50% or more. Diagnosis is done through vascular tests such as arteriography and ankle brachial index. Management is through lifestyle changes, pharmacotherapy, and skincare. Signs and symptoms of arterial insufficiency: painful with walking, Elevated foot develops increased pallor. Venous filling delayed following foot elevation. Redness of the distal limb. And death of tissue, known as gangrene. A thrombus is a solid mass of platelets formed within the blood vessel. An emboli is pieces of a thrombus that break free and travel through the bloodstream to other parts of the body. Acute venous disease includes thrombophlebitis, which is inflammation of a vein due to a clot, and chronic venous disease, which includes varicose veins and chronic venous insufficiency. Venous thrombosis is a partial or complete occlusion of a vein by a thrombus leading to inflammation of the vein wall, intravascular collection of platelets, erythrocytes, leukocytes, and fibrin, and can result in significant morbidity and mortality. Types of venous thrombosis include superficial, that affects veins near the skin surface, or deep, which affects deeper veins. A deep vein thrombosis, or DVT, is the third most common cardiovascular disease following acute coronary artery episodes and cerebrovascular disease. DVTs occur in 30 to 60% of post-surgical patients up to 4 weeks post-surgery, and it most commonly affects the lower extremities. Etiology involves genetics, lifestyle factors, venous stasis, hypercoagulability, and venous wall injury. Pathogenesis is endothelial trauma of vein walls, exposes platelets and clotting factor leading to a thrombus. Clinical manifestations initially may be asymptomatic. Early symptoms may be dull, ache, tight feeling, or calf pain. Progressed symptoms involve warmth to touch, discoloration, pitting edema, calf pain, superficial vein dilation, and a positive Homan's test. Pulmonary embolism is a pleuritic chest pain discomfort, tachypnea and tachycardia, restlessness, and dyspnea. Diagnosis for a DVT involves Wells' clinical decision rule, which is used to assess the probability of a DVT, and Doppler ultrasonography, which is common imaging modality for diagnosing DVTs. Management involves anticoagulation, bed rest, and elastic stockings to prevent blood pooling in the legs. Prevention involves early ambulation, anticoagulants for major surgery patients, frequent position changes, compression stockings, and exercise. Precautions involve positioning the limb below the horizontal plane. This prevents blood from pooling, protecting the skin to prevent pressure ulcers, and avoid thermal agents and massage, which are contraindicated to avoid dislodging the thrombi. Arterial insufficiency can be anywhere on the leg or the dorsum of the foot or toes, bone prominences, and lateral malleolus. Clinical manifestations include pain, especially when the legs are elevated, poor or absent pulses, intermittent claudication, pain in the foot or forefoot that is relieved by dependent dangling position, changes in the skin such as hair loss, thinning, or shiny skin, ischemia, which can lead to pale or white skin color, sluggish blood flow, hypersensitivity to palpation. The wound appearance may have minimal exudate with dry necrosis and blanched wound base and peri-wound tissue. Venous ulcers due to venous insufficiency are generally located on the medial aspect of the distal 1/3 of the lower leg behind the medial malleolus. Clinical manifestations include pain, aching pain, normal arterial pulses, eczema or stasis dermatitis, edema, and dark pigmentation in the peri-wound area due to leakage from blood that cannot return to the vascular due to vascular incompetence. The wound appearance is superficial, highly exudative, red wound based, and irregular edges. Vasomotor disorders. An example is Raynaud's phenomenon. This is intermittent episodes of small artery or arterial constriction in the extremities causing temporary pallor and cyanosis of the digits and changes in skin temperature. It's triggered by cold temperatures or strong emotions like anxiety or excitement. Raynaud's disease is a primary idiopathic vasospastic disorder causing these episodes. Raynaud's phenomenon is a secondary to underlying disease or condition. Pathogenesis involves blood vessel constriction leading to reduced oxygenation, resulting in pale and cold skin. Clinical manifestations include pallor and cyanosis of the digits, temperature changes in the skin, and episodes triggered by cold or emotional distress. It's diagnosed through clinical presentation, typically for at least 2 years. There's limited pharmacological management due to the idiopathic nature. During an exacerbation, gently rewarm fingers or toes by placing them in the axilla. Wiggle fingers or toes or move and walk around to improve circulation. And if possible, run warm water over the affected area until normal color returns. Management involves avoidance of provoking stimuli such as cold or emotional triggers. Here's a list of skincare and protection for individuals with vascular disorders. Orthostatic hypotension or postural hypotension is a decrease in systolic blood pressure of 20 millimeters of mercury or more and diastolic blood pressure of 10 millimeters of mercury or more in both systolic and diastolic. It's accompanied by an increase in pulse rate of 15 beats per minute or more upon standing from supine or sitting position. Etiological factors involve normal aging that slows postural reflexes, reduces cardiac output, and predisposes older adults to orthostatic hypotension. Also changes in aging with hypertension. This further increases susceptibility to orthostatic hypotension and drug use, which is a significant cause, especially in older adults. Pathogenesis involves impaired vascular resistance. So there's reduced capacity to increase vascular resistance caused by pooling of venous blood. The pooling leads to decreased stroke volume and cardiac output and results in decrease in blood pressure upon standing. Clinical manifestations include dizziness, blurred vision, syncope, falls or mobility problems, acute or chronic mental confusion, and cardiac symptoms. The mode of presentation involves falls or mobility problems, acute or chronic mental confusion, and cardiac symptoms. Management is correction of the underlying cause, so addressing contributing factors such as medication or dehydration, and the use of a tilt table testing, which is used to assess the person's blood pressure upon postural changes. Orthostatic hypotension and exercise management. It is important to monitor blood pressure in various positions. This is how it could be documented. First, you take the blood pressure in a supine position. Repeat blood pressure at 1 and 3 minutes after transitioning to sitting or standing. Habituation to upright is the goal. Must be identified immediately and carefully monitor patient. Monitoring for signs of angina, and also other vitals such as oxygen saturation and heart rate. PTA implications involve being mindful of medications patients are taking, be mindful of interventions that cause vasodilation. Cool down periods are essential to control the abrupt decrease in venous return. focus on aerobic conditioning, habituation to upright technique, instruct patients to rise slowly after long periods of recumbence. The doctor may order the use of abdominal binders and stockings. If showed signs and symptoms, patients should assume supine position with lower extremities elevated, unless contraindicated. Here's a list of antihypertensive medications. Other cardiac medications. Laboratory tests and values specific to cardiovascular disorders. Back to our questions. During a cardiac rehabilitation session, a patient reports chest pain and shortness of breath. The PTA measures the patient's blood pressure and finds it to be 90/60 millimeters of mercury. What is the most appropriate immediate action? The correct answer is D. Call emergency services and initiate emergency procedures. The second question is, a patient in an outpatient clinic is participating in a structured walking program. Post myocardial infarction, the PTA monitors the patient's vitals and notes an oxygen saturation of 92 with a heart rate of 110 beats per minute. The patient reports mild fatigue but no chest pain. What is the best course of action? The answer is A, continue the exercise session while monitoring symptoms. If you like this video, please make sure to like and subscribe.